Aye, Doc.
All right, so question 4 is another long one, so I'll read it, right?
Yeah.
Hey guys, big fan of the show. Thank you. I've got a question my test doctor hasn't got an answer for. And I don't think I've heard you guys talk about this. I'm almost 2 years into replacement. I was doing it without doctor supervision for a year and a half. I started at 150 milligrams a week of testosterone and anthate for the first year. Labs were stellar. Up my dose to 240 milligrams a week for about 6 months. Decided to consult a testosterone clinic doctor for a consult and some in-depth labs. Labs were all great, except my hematocrit was 51.1 and my estradiol was 50. I donated blood for the red count and the doctor prescribed me anastrozole 1 milligram a week. Here's where it gets weird, oh boy. I took the first AI and felt completely off, to the point I went to my primary and got some SSRIs for anxiety over how off I was feeling. The testosterone doctor said, don't take any more of the anastrozole. He said, maybe we'll try a lower dose later. Fast forward 4 months, and I've lowered my dose to 200 milligrams a week of testosterone and anthate and split the shot every 3.5 days, testosterone doctor's recommendation. It felt off while adjusting to the lower dose for about 2.5 weeks, then was back to normal. I decided to try a 0.5 milligram of anastrozole to see what that would do. The first 24 hours afterwards, I was definitely jacked up on tests. Anastrozole increases free testosterone by blocking conversion, right? No. I mean, well, we'll get back to that. The next day it crashed. At my next injection, I didn't even get the standard mood elevation I usually get 24 hours after. I'm 3 injections in after a half a dose of the anastrozole and still haven't baselined back to normal. Feels like when I dropped from 240 to 200. I'm sure it'll all fall back in line shortly, but I was wondering if you've ever seen this. And for the record, as soon as I get back to normal, I'm dropping my dose again. I'd like to get back to 150 a week and stabilize there, then recheck my estrogen. In addition, I've never had any high estrogen symptoms, and my trough total testosterone levels were 875 6 days after 240 milligram injection. Any help would be greatly appreciated, Michael. All right, so yeah, long question, a few things to address. First of all, the most glaring, for me anyway, is the estradiol of 50. The problem with an estradiol is it's made to measure a woman's estradiol level, which can go from typically can be close to 0 if they're menopausal, but a healthy female that's even perimenopausal, but let's say premenopausal, is going to have an estradiol anywhere from, let's just make it easy, 100 to 400 picograms per milliliter. So the standard estradiol test is not precise enough at the lower levels required or not required, but are typical of a male to be accurate. So an estradiol, the standard estradiol, 50 could be 20, 50 could be 80, who knows? It's very imprecise and therefore very inaccurate. We need an estradiol sensitive, and I think that might be what's going on here, because the symptoms he's describing could be secondary to estrogen being oversuppressed. It's easy to talk about the hematocrit. A hematocrit of, he said 51.1, that's not that bad, and could be simply because, we need to address, is this because you're at elevation? But the testosterone, whatever's going on, the testosterone leverages, doesn't cause it per se. That's a common mistake even doctors make. Oh, you're on testosterone, that's why your hemoglobin and hematocrit are way too high. Well, it can raise it, just as it can lower it. I've seen guys with low testosterone that are anemic, meaning their hemoglobin is below, depends on the lab standard, but roughly 13, some 12.6. It'll leverage what's going on. Oftentimes it allows us to find out someone's got sleep apnea. So they're not breathing well in their sleep, they're going into oxygen debt, all the mechanisms kick in, like just as though you're training in your sleep to make more oxygen carrying capacity. The red blood cells which comes into the hematocrit percentage and the hemoglobin, the oxygen carrying capacity, right? So again, the testosterone will leverage that effect. If you're at altitude, you're already sort of training in your sleep because you're in an oxygen, not debt, but you're in a non-rich oxygen environment. So these numbers can come up just by adding the testosterone. I don't think that's his concern, and certainly that wouldn't be a reason for your feeling off a hematocrit of 51.1%. And I'm assuming a lot of things here because I don't see measurements in all these things, picograms per milliliter, nanograms per deciliter, all that sort of thing. A testosterone total of, I'm assuming, 875 nanograms per deciliter. On average, that's going to be a 16 or a 17 free test, picogram per milliliter free test. Again, I'm making some assumptions here. Never had high estrogen symptoms before is getting back to what I'm trying to make the point about the estrogen. Well, maybe you never had high estrogen, and this is a laboratory result that's not accurate. So you were over-treating it from the get-go because you never had high estrogen. Something to consider. You can feel anxious with low estrogens. Can make for heart palpitations. Just like, think of a standard menopausal woman and the symptoms associated with her. Night sweats, hot flashes, heart palpitations, anxiety. So that's something I would start with. Let's get an estradiol sensitive and see what's really going on with the estrogen. One of the mechanisms by which you can avoid having to use an anastrozole, and some people do have a reaction to the anastrozole, whether it's the medication itself or their metabolizing of it, not normally, meaning it goes in too fast, or the 1 milligram dose is too much, and so while you might get away with half milligram the day after a shot, you do a milligram. It's too much and you have symptoms right away, but then they go away in a couple days, which I'm not sure if he's describing that kind of fluctuation. But you can reduce the need for anastrozole by dividing the dose. The body likes that homeostatic range. The further you get away from the edges of that range, if you will, the more your body tends to overreact. So if you're just a little above normal, you won't have as much conversion. I say above normal, testosterone. You won't have as much conversion to estrogen as if you were, 3 times normal, right? So one smart way of adjusting the dose of anastrozole downward if it's required and if it's being used is to break up the dose. It means one more invasive procedure. Granted, it's just a shot, but it's also literally sometimes a pain in the rear. But I think that's a smart move if we're trying to use less anastrozole or try and exclude that from part of the differential diagnosis to what might be causing the problem. You could also try using just a serum, good old tamoxifen, and see if it's truly an issue with anastrozole, the medication itself, or the reaction to its effect, because it's a totally different mechanism. You're not going to block the conversion, you're just going to block at the receptor with tamoxifen. So a couple things you can do to try and tease out what's really going on here. The dosing of the testosterone, that's really more of a factor of, and I know it's getting confounded by the use of anastrozole or whatever we're going to use to block the estrogen, but how are you feeling? Again, you could tell me your total testosterone is 875 or 450. I don't know what that means, except in conjunction with how you're feeling first and foremost. Again, you always treat people, not numbers.
Yeah.
But so again, I apologize. I can't do a better job with these questions, but I need more answers to questions. I need more, and this is supposed to be general anyway. But I want to give you as much detail, avenues to pursue anyway as I can, without going too many ifs and what ifs and all that kind of stuff.
Yeah.
Did I miss anything in the question though?
No, I think that was good.
Okay.
Yeah.
So I would pursue, the easiest one to pursue is starting with the estradiol sensitive testing and see really what's going on with the estrogen. Maybe floating estrogen up higher than what would be my preference. Oh, I said we get back to testosterone. Yeah, technically speaking, obviously if you're blocking the conversion from testosterone into estrogen, you're going to have you're going to be sparing some testosterone, right? Which is one of the great ideas, I think, behind using an aromatase inhibitor. Instead of letting it convert and then just blocking at the receptor, which is what tamoxifen use would be doing, right? So technically, yeah, you're going to spare more testosterone, but not necessarily free. The only way you tend to get more free testosterone by lowering the sex hormone binding globulin with an anastrozole or any AI is by getting it to this tipping point that, we don't know why it works this way, but I found in practice somewhere around 22, 21 picograms per milliliter of estradiol sensitive. All of a sudden, the free T rises, sex hormone binding globulin drops. So if you got it low enough, yes, that's one of the mechanisms by which usually you can raise your free T, but that way, not some other way, which I think is being applied here.
Yeah.
Okay, I think I hit it all.
Yep, that's good.
All right.
Thanks, Doc.